welcome to our Building Bridges Lenox Hill series for heart health. Tonight, we have a very interesting topic, and we're very excited to have you here tonight. We are going to be talking about getting to the heart of LGBTQ health. And tonight, I have joining me two of my amazing colleagues who are from different disciplines as part of a multidisciplinary team that we have here at Lenox Hill. So Dr. Caroline Ong is the Associate Director of our Lenox Hill Echo Lab, and she's also the Director of our LGBTQ Cardiovascular Health Center. And Dr. Minghao Liu is an excellent endocrinologist in various fields of endocrinology, but her expertise for tonight is she's the director of the Friedman Transgender Health and Wellness Program. So, you know, I've been at Lenox Hill in Northwell for a number of years now, and I was fortunate to sort of arrive at my office and to learn that there was this fantastic transgender center in place, that there was a focus really on LGBTQ care, and I'm very lucky to work with people who have an expertise in this area. So tonight, what we're going to do is first we're going to hear from Dr. Ong about this topic. She'll give a short presentation, and then we're going to really have more of a discussion and talk about issues and what it is in healthcare that we can improve in this area. So feel free to chime in if you have any questions. Put them into the chat. We'll be answering those for you, and we look forward to discussing. So welcome, ladies, and Dr. Ong, feel free to get started.
Great. Thank you, Dr. Janos. I'm going to share my screen. Let's do this. Let's share. And can everyone see my screen? Can we see my screen?
Yes, we can, definitely.
Okay. Excellent. Thank you. My name is Caroline Ong, and I'm the Director of LGBTQ Cardiovascular Health at Lenox Hill Hospital and at Lenox Hill Greenwich Village. As Dr. Janos says, this is a new program that we are starting, so I'm very excited to be talking to you about it tonight. It's a slightly later start to the general Building Two Bridges series. So first, I want to thank all of you for joining us for this very important discussion this evening. As you may know, Northwell Health and Lenox Hill Hospital has a long history as a leader in healthcare equality and excellence in New York, as well as nationally. And so in line with that, in 2021, we established a unique program that is focused on caring for the cardiac health of our LGBTQ patients. So I think we've all heard at least a little bit about LGBTQ heart health issues, whether it's from the news or from friends and family, or maybe even from your healthcare provider or your doctor. However, most of the queer health issues that we hear about usually center around HIV/AIDS, mental health, substance use, and even newer infectious diseases like monkeypox. And while these are important topics to address to keep our community healthy, today I'm going to talk about a topic that is often under-recognized in LGBTQ health. First, I'm going to highlight the specific risk of heart disease in adults who live and identify as lesbian, gay, bisexual, transgender, non-binary, or queer. We'll also evaluate the causes of these persistent inequities in queer heart health. And then finally, we'll segue into a discussion of ways we can prevent and reduce heart disease in LGBTQ patients. Throughout this talk, you may hear me use the terms LGBTQ, queer, or sexual and gender minority, or SGM, pretty interchangeably. These terms are evolving, and I want to make sure to acknowledge and appreciate the diversity of all identities of the communities. We won't get into all of them, but these are some common terms that you may have heard of. Queer was historically a derogatory term, initially used against LGBTQ people. But since the Stonewall riots and subsequently, it has been embraced and reclaimed by LGBTQ communities. So today, queer is often used to represent all individuals who identify outside of other categories of sexual and gender identity. Queer may also be used by individuals who feel as though other sexual and gender identity labels do not adequately describe or capture their experiences. Other important terms to know are gender identity, which is a person's inner sense of being a man or a woman, or a combination of that, or having even no gender at all. Everyone has a gender identity, regardless of whether you identify as cisgender, where your gender identity aligns with the sex that was assigned to you at birth, or transgender, where your gender is not congruent or does not align completely with the sex assigned to you at birth. So, as you know, cardiovascular disease does not discriminate. It remains the leading cause of death and disability in the US today. The good news is that up to 80% of premature heart disease and stroke are preventable, and we've come a long way in our ability to understand, prevent, and treat heart disease. Between 1990 and 2013 alone, we saw death from heart disease decline by over 20% in the general population in the US, thanks to rapid advances in diagnosing and treating cardiovascular disease. However, unfortunately, this good news is not distributed equally. There are about 23 million Americans today who identify as LGBTQ, which comprises about 8% of the total US population. And when we look at even younger adults, up to 16% of people who identify as Gen Zers, that is being born in the mid-1990s onward, they identify as a sexual and gender minority. So this is a growing community. And so in spite of the big declines in rates of heart disease that we've seen in the US over the past 20 years, we're really starting to understand that lesbian, gay, transgender, and queer adults continue to experience significantly increased cardiac risk factors and have poorer heart health when compared to their cisgender heterosexual friends. We also have emerging evidence that shows that lesbian, gay, bisexual, and transgender adults are 36% less likely than cisgender heterosexual adults to have ideal heart health based on 7 leading risk factors that your cardiologist is traditionally most concerned about when it comes to your risk of developing heart disease. And these risks include things like tobacco use, the amount of physical activity you get or may not be getting, your nutrition and diet, your weight, your blood pressure, and your blood sugar. And these are the same health habits and factors that we try to modify when you come see us in clinic in order to protect your heart health and reduce your risk of heart disease. We'll get into some of the reasons for these differences in a little bit, but when taken as a whole, these persistent disparities in health habits really do translate into real risk for the queer community. For example, LGBTQ adults report more tobacco use than their cisgender heterosexual friends. And there's a higher proportion of gay, bisexual, queer men who have elevated blood pressure when compared with straight men. Also, when we compare women who identify as lesbian, bisexual, queer with heterosexual women, we find that sexual and gender minority women are more likely to have diabetes and obesity for a multitude of reasons that we will delve into. It's not always doom and gloom. A recent study did show that transgender adults who want to and are taking gender-affirming hormones had greater body satisfaction, and this is subsequently associated with increased physical activity. So this may suggest that having a supportive environment and gender-affirming care can play a role in promoting physical activity and improving your heart health amongst transgender people and other gender minorities. But even when we account for and exclude these 7 different risk factors, what we call traditional cardiovascular risk factors, LGBTQ adults still face significant residual risks to their cardiac health. Excuse me. In fact, the CDC Behavioral Risk Factor Surveillance System, which is an ongoing national surveillance tool, recently found higher rates of heart attacks among LGBTQ people, even when you adjust for those risk factors such as age, diabetes, high blood pressure, high cholesterol, kidney disease, smoking, and the lack of exercise. So how can we explain these differences in risk and disease? Well, we know there's a strong mind, body, and heart connection when it comes to stress. And chronic stress in particular can directly impact certain hormones, such as cortisol and adrenaline, norepinephrine that regulate our blood pressure and our heart rate. So the general stresses that we all, including lesbian, gay, bisexual, transgender, and queer adults face at work or in our personal lives, they may be compounded by minority stress, such as violence, discrimination, and social isolation. And there is extensive evidence that shows that exposure to stress-related discrimination and stigma can lead to unhealthy coping behaviors, such as substance use, and can arouse psychological and physiological stress reactions like depression and anxiety that has been shown to negatively affect your heart health. So all of these stresses, be it financial, social, and familial rejection, work discrimination, they can cause cortisol and inflammation levels to surge and to stay elevated, which can then lead to long-term cardiovascular issues. So in addition to the 7 traditional cardiac risk factors that we talked about, lesbian, gay, bisexual, transgender adults are also disproportionately affected by additional risk factors, such as alcohol use and substance use, sleep disturbances, HIV and AIDS, and inflammation, and its effects on vascular function that may be overlooked by patients and health providers and doctors alike. Later with Dr. Minghao Liu, we're going to spend some time discussing transgender and gender non-binary care. She's the endocrinologist who is really an expert at helping transgender patients align their gender identity with their appearance using gender-affirming hormone therapy. I will say here that while transgender identity does not necessarily mean that a person will alter their physical appearance through surgical or hormonal interventions, about 80% of transgender people report having used or plan to use gender-affirming hormone therapy. And research tends to support that such therapy can reduce symptoms of anxiety and depression and improve a patient's quality of life, particularly when used along with other psychosocial support in order to allow the individuals to attain gender congruence, which is a state where a person's gender identity aligns with their outward appearance. However, despite the known benefits of gender-affirming hormone therapy, we do not yet have strong quality data on the effects of these therapies on cardiac health. It remains an ongoing area of research. So it may not be surprising to hear that transgender patients are exposed to additional heart risk. We don't completely understand the mechanisms of these risks, but they may be associated with the use of hormone therapy as well as with chronic stress. So it's important to keep in mind that when starting or maintaining gender-affirming hormone therapy, it may change your cholesterol levels and blood pressure. And this is something to discuss with your doctor. We have also observed more ischemic strokes and blood clots in transgender women on feminizing hormone therapy. So this is a factor that we take into consideration for people who have these underlying conditions. Because of such uncertainties and risks, it's important to recognize that gender-affirming hormone therapy should be individualized in each patient in order to both optimize their cardiovascular health while enabling each transgender person to achieve a congruent gender identity. Finally, and this is often difficult for the medical community to discuss, there are also systemic barriers in healthcare that we are working to improve. In New York and across the nation, there are still persistent health system barriers for LGBTQ patients to access appropriate and culturally competent healthcare. In a recent large survey conducted by Lambda Legal, more than half of LGBTQ adults and over 70% of transgender and gender non-conforming patients have reported experiencing some form of discrimination from a healthcare provider. And what's even more alarming is that 8% of LGBTQ and 25% of transgender patients have been denied healthcare by health clinicians. So perhaps it's not surprising to learn that many LGBTQ adults lack trust in their healthcare providers and may delay care due to prior negative experiences and fear of discrimination, whether it's actual or perceived. So there are still gaps in our knowledge of cardiac care for queer people. Only 4% of all NIH-funded studies on queer health focuses on heart disease between the years of 1989 and 2011. And since then, funding has not significantly increased. So this is another area that we're actively looking to change. what else can we do to reduce these disparities? Together with the American Heart Association and the American College of Cardiology, we at Northwell Health are working on several strategies to improve access to LGBTQ competent care. This means increasing awareness and education among patients and providers. We're partnering with local LGBTQ organizations to identify barriers to care and promoting diversity training at all levels. We're also changing the structures of our clinic and hospitals to make it more affirming of sexual and gender minority experiences. And then finally, to address some of our knowledge gaps, we're also working on increasing representation of gay, lesbian, bi, and trans people in cardiology research to better understand the unique risk and needs of our LGBTQ community. So if you are an LGBTQ person or have an LGBTQ friend or loved one, there are several steps that you can take to improve your heart health. First, find a provider or a doctor that you trust. You can try asking for referrals from your friends. Check out a local LGBTQ organization like the Gay and Lesbian Center, or a healthcare provider, or ask a healthcare provider that you already trust. Try to learn your numbers by keeping track of your blood pressure, weight, cholesterol, and blood glucose number, which is often reported as an A1C, so that can help you keep track of how you're doing over time. It's also important to prioritize a healthy lifestyle, and you can do that by cutting down on alcohol, avoiding smoking, exercising regularly, and eating a heart-healthy diet. So, and then at your next medical visit, discuss your health habits and substance use, and ask your healthcare provider how you can reduce your risk for heart disease. If you want to take an even more active part, you can also consider participating in research studies. We have a number of them at Lennox Hill and Northwell, and you can help us learn more about LGBTQ heart health. So that concludes my segment of the talk, and I want to lead our discussion segment with Dr. Liu and Dr. Janos. And I want to start it by saying that it's important to recognize that the L does not equal the G, does not equal the B, does not equal the T or the Q. So our goal is to individualize cardiac care as much as possible for each sexual and gender minority, because each person's journey and experience with their health and their sexual gender and gender identity is different. And with that, I thank you.
Thank you, Caroline. That was an amazing talk. And I like that, actually, the non-equal, because, you know, I think all of us
I think you're still muted, Eugenia.
Sorry.
We can hear you.
Okay, I think, yeah, there we go. Okay, I'm back here, I think. So yeah, so thank you. I think because I like the sort of emphasis that they're not equal, because in some ways, we, in an effort to create equity, kind of like want to say, well, just treat everybody the same, you know, whether it's, you know, we're talking about men, women, we're talking about different races, ethnicities, you know, sexual orientation, et cetera. But you have to, in order to promote equity, you kind of have to understand and respect that there are differences in different populations and communities, and be aware in the sensitivities and what people really are experiencing. So it's actually a different approach than just saying, like, you know, treat everyone the same. Really be aware of differences and raise that awareness, which is great. Excellent. So I'll start, I guess, first with asking both of you specifically, you know, where you see the gaps in healthcare, and, you know, your biggest focuses on where we can change the system throughout the various health systems, and what patients are really experiencing.
So I can start, Aldo. So I think that, you know, that there are still a lot to be done. There's still a lot to be done. But it's heartening that we have gotten a lot more recent support from the societies, as I've mentioned, and, you know, all of the major societies and AHA and ACC have recently published strong statements recognizing the gaps in knowledge and the continued work that needs to be done, and encouraging continued efforts to both capture the data as well as to implement some changes. to allow us to be more inclusive in our care. I think that one of the biggest gaps that I see still is physician and health provider unfamiliarity, and with patients who may not identify as as cisgender or as heterosexual. It's not, and often it comes from a place of fear and rather than a place of hate, and I think that, or discrimination. And I think that it is important for us to continue to educate patients and physicians on how to negotiate that and to learn and ways in which they can empower themselves to learn more. And whether that is having diversity training, which is a constant effort on our end, as well as increasing the number of publications that we have, and empowering our patients to say, hey, this is my identity, and that I would like us to be able to talk about it. Unfortunately, it is part of minority stress, but it is also with great power comes great responsibility, and I think the onus is unfortunately sometimes still falls on the patient to show providers that they are there and that they also deserve care.
I think that's a very good point, Caroline. It's not the onus of our patients to educate us, right? Yeah. So we should all be undergoing diversity training. We should have representation in terms of our staff. And we should have people in these communities who are on our staff. So we should be increasing employment opportunities. And so from my point of view as a gender affirming hormone provider, what I see as some of the gaps in care is that, transgender patients and LGBTQIA+ patients in general tend to have a higher rate of obesity and being more sedentary at baseline. And that's a variety of reasons, including some of the ones that Caroline has mentioned, including body image, fear of stigmatization, verbal and physical attacks when they go out in public. And then when you have that baseline increased rate of obesity, and the rate of obesity in the American general population is already pretty high. It's pushing 40%, right? So when you have that baseline and then you start hormones, what a couple of studies have shown is that people who are on testosterone tend to gain more weight than people who are on estradiol, like 6 to 21 months after starting hormones. So then that adds to the risk that is already present when you have increased weight. And in addition, when you start testosterone, that can increase triglycerides, which is a bad cholesterol, and decrease HDL, which is a good cholesterol. So that again is a synergy to compound cardiovascular risk, which can increase the risk of heart attack and stroke in the future. So we have to be very mindful of these things. And if people already have high cholesterol, whether it's due to genetic factors or a combination of genetic factors and diet, sometimes it can be very hard to lower that. So, we typically give statins for people who are older than 40, right? I mean, we can give it for people who are younger, but we usually don't. But maybe we should, because in a lot of our younger populations, just to use a case example, so this is actually a patient that Dr. Gianos and I share. So this is a young patient, trans man who was disowned by his family, living in a shelter, very fixed income, has $200 a month to spend on food. And when you're living in New York City, right, what can you buy with $200? So to lower things, LDL, you should be eating lower foods that are lower in animal fats. You should be having more aerobic exercise. And to lower triglycerides, you should be having less simple carbs, less processed carbs, right? But when you have such limited income, the easiest thing is just to buy like frozen dinners from the supermarket, which are very high in terms of processed foods. So socioeconomic circumstances and familial circumstances and support can be very limiting when it comes to, decreasing the risk that's already inherent and remedying some of the, increased risks that are present.
Yeah, I think you highlighted really nicely what, Caroline brought up, which is actually a really good point. You know, in general, what we're comparing this to is the cisgender heterosexual population who are already not doing so great with their risk factors. Like you said, they already have obesity and cardiovascular disease. And when you're talking now about 36% higher, rates of cardiovascular disease and more obesity, and then maybe more on the hormone, I mean, we're really, leading to a big problem that just needs to be proactively addressed. And I think it is definitely a great thing, to have these collaborations. We are working both clinically, or we happen to have clinics right across the hall from each other. So it really works out well with our endocrine and cardiology. But, it's really nice for patient care to have everyone sort of discussing things. And, we do this also, with menopausal women going on hormone therapy. We do this with men who have testosterone deficiency, requiring testosterone replacement. There are many people getting hormone therapies, and we need more research in general about hormones in general, because the data has also been all over the place. Unfortunately, even with the women's literature, it's, don't ever use this for women. No, it's a good idea. No, it's about it. There's a lot, it's a complex picture. But at the very least, assessing each patient individually, knowing what their risk is at the baseline, and knowing what you can potentially improve, as you mentioned, like sort of proactively knowing, well, what can we do to help both with lifestyle, meds, and even the social determinants of health? Where can you support them, which you guys have a psychologist, and partnering with patients as well. And we do actually, for select a number as well. So I think it's really important to get that whole picture, as you mentioned. Great. So yeah, and if you can just share with us a little bit of, still, since we're talking about the hormones, just because, when we are doing a research project looking at cardiovascular health and bone health with their division with Dr. Natalie Cusano, Dr. Len Paretsky, and myself and Minghao. But one of the things that's interesting in looking at the literature is there's differences in the way hormones were given, for example, in the past, what's being used now, how we think about this. So, what is important for both physicians actually and clinicians to be aware of, who may not have any idea how this stuff happens, and also for patients to be aware of, as some of them truthfully are getting these in random places sometimes, like getting these doses from different places and maybe not aware of what are the hazards, what is important to do.
Yeah. So for trans masculine care, or people who are assigned female at birth and want to become gender non-binary or more masculine, usually we give testosterone. So that is enough to block the female reproductive axis, and testosterone is available in the form of gel, injections, and pills actually, but the pills are usually prohibitively too expensive. So realistically, we're looking at injections, gel, and sometimes patches. For trans feminine care, we use bioidentical estradiol, which is 17-beta estradiol, which comes in the form of patches, injections, and also pills. And then we also have to use a androgen blocker most of the time. And in the US, that is most commonly spironolactone, which actually, as the cardiologists know, was developed for heart failure and reduces, rehospitalization and mortality for people with heart failure. So, but it blocks the synthesis of testosterone and the binding of testosterone on androgen receptors. So the estradiol most of the time is not strong enough to fully block the male reproductive axis. So we add on spironolactone. So when it comes to trans feminine care, it's very interesting because, years and years ago, like 10, 20 years ago, we only had synthetic hormones, which were ethinyl estradiol and also these conjugated estrogens, which we purify from horse urine, actually. So those are associated with a lot more risk of deep vein thrombosis, which is blood clotting, as well as breast cancer, heart attack, and stroke. So nowadays we use the bioidentical estradiols, which have a lot less risk of all of that. But in terms of the different formulations, so the oral estrogens are more likely to cause blood clotting. We think that, it increases, well, we don't think, we know that some studies have shown that there's more inflammatory factors with the oral estradiols because it undergoes first pass effect by the liver. So if somebody is already, at risk of blood clotting, like if they're smoking, first of all, they should stop smoking if they're going to take estradiol, so any kind of estradiol. But it's hard to stop smoking, as people who smoke knows. So if you're in the process of smoking cessation, then the safest formulation of estradiol is the estradiol patch, which is transdermal and bypasses the first pass effect that's seen with the pills. So that's one consideration. Another consideration is that, when starting testosterone, as mentioned, weight usually increases, unfortunately, and it usually increases, and body composition usually changes in a fashion that is not favorable cardiometabolically. So people tend to gain weight in the midsection, and when your waist circumference increases, that also increases the risk of heart attack and stroke. So I'm very careful to counsel patients who already carry excess weight before they start testosterone. Counsel them on starting an aerobic exercise regimen, on decreasing the intake of processed foods, simple carbohydrates, try to have more of a high protein, low carb diet, and, try to lose weight before starting testosterone. Not that, that would be a barrier for them to start, but definitely something that we're very mindful of.
That's really great advice. Yeah, no, absolutely. I think just proactively managing all that, and the fact that you provide a full program of, you have an exercise trainer, even you have, what do you call it, a dietitian that partners with them, being able to offer all of that to a patient is really, really key. So Caroline, you and I deal with the cardiovascular side of this. So maybe you can tell us a little bit about risk stratification and most of the patients that I've seen in this space have been pretty young, I would say. I don't have that many even over 50, and I think in your center too. So we're still talking about young patients, but yet we know that, in general, we are seeing higher rates of heart disease in young patients too. It's a little bit surprising, but how do you approach these patients, and, what do you do in terms of assessing their risk?
Yeah, I agree. I think the majority of patients who come to me are younger, and they come for other reasons, other cardiac concerns other than hyperlipidemia and diabetes, such as palpitations or heart arrhythmias, trouble breathing, chest pain from various causes. So but in all of these patients, I do a risk assessment in addition to the workup for the other conditions that generally includes lipid profile, close monitoring of the blood pressure, as well as close family and social history to get a better sense of what the health habits are, as well as potential familial risk factors that we may have. So if a patient has a father who had an early heart attack, then my index of concern is elevated, and I may do additional testing. Or if the initial lipid panel comes out elevated, and they are on a hormone therapy that we know have causes poor alterations to the lipid profile, then we may do additional testing. And some of these testing, depending on the age and other factors, could include things like an Lp(a), which is an additional subset of cholesterol, of lipids, that can add to our understanding of the overall risk. I may also check other things in your blood, like CRP, which is an inflammatory marker that can also give us some indication of what your overall risk for heart disease is. And then there are additional testing, such as looking at your vasculature using ultrasound technology, that can also inform us. And then based on all of these things, and I will have a heart-to-heart talk, literally and figuratively, about what their overall risk is. And, we do and make a shared decision in terms of when and how much lifestyle modification they feel like they're able to do, and the time points in which we'll check in on them. I think that the age at which we start a medication, like statin or other kinds of medications to lower your cholesterol, has been evolving. And so depending on the patient, I may start someone younger than 40 if their risk profile is particularly adverse for heart disease. And then, what we do is also have them come back and check in on a regular basis. So this isn't a one-off consultation. So this are some things that we try to address with all of our patients, regardless of the initial presenting.
Yeah. Thank you for that answer, because I think you just summed up the whole field of cardiovascular prevention. It's really an individualized approach where you get every single component of the patient's background, as she described, like what's your family history, what's your lifestyle like, what are your medical problems, what are you at risk for, and then using individual to that patient, whatever testing might help you, figure out the clues and know exactly how to manage the person so that they stay healthy for the rest of their lives. And that's the best thing you can do. And also, I think, in working with Minghao and her team, if it's really important for them to get the gender affirming hormone therapy, and it is actually going to improve how they feel about themselves, how they're able to manage their lives and, do things, then to safely get them to there, aside from the lifestyle, sometimes we'll say, we'll feel more comfortable based on your cholesterol levels and your family history if you're taking that statin from now and preventing heart disease while you take that, therapy. So, there's definitely ways with the team approach, I think, to keep somebody safe, make sure we optimize health as much as possible. Yeah. And Minghao, from your side, are there, I guess you're constantly weighing, both sides and everything. Is it common that you feel that you have to tell people that, the risk is just too high in your case? Is there, and I know that you guys do nowadays use safer options, and this is how we do it with menopausal women as well, sort of starting low, slowly increasing, trying to be safe. But are there cases that worry you that you would say, probably not the best idea here?
That's a great question, because these challenges do come up. So a couple of examples that I can think of are a trans feminine person who is in their 70s, who has a factor V Leiden mutation and has had a blood clot before while they were on estrogen. So this was when they were on oral estrogen. So they strongly want to be back on hormones, right? And the thing is, this is life or death for them. To not be on hormones creates an intense sense of dysphoria and, a deep depression. So in that case, what I did was to refer them to hematology to see if there's anything that we can do to mitigate the risk of recurrent blood clots while, they're on the hormones, because, this person is going to take hormones no matter what, whether I prescribe it or if they buy it on the black market. And if they buy on the black market, it's most likely going to be birth control pills, which has synthetic estrogen, which carries even higher risk of blood clotting than, the bioidentical estrogen. So in cases like this, I would say most of the challenging cases are in people who have coagulopathies, which are pathologies in which they're more prone to develop blood clots in the general population. Because if it's a case of, high cholesterol or excess weight or something like that, those are modifiable risk factors that, we can treat with statins or PCSK9 medications. So, but the blood clotting is a little bit trickier. So I would like to have a hematology colleague on board. But I think the bottom line is, we all have free will, right? So we have to have an informed consent discussion with the patients, because, people who don't get the hormones, for gender affirmation, they may be so depressed that they commit suicide, right? So that is a very rapid termination of life. So we have to weigh everything. And, patients who are, intelligent and are able to provide informed consent can make that decision for themselves.
And, I think you bring up an interesting point. I think the risk benefit calculus is a lot, it's different when we're thinking about primary prevention and maintaining gender congruence with hormone therapy versus secondary prevention. And unfortunately, there isn't a lot of data. We have some expertise consensus about what to do. If, for example, if a patient has had a heart attack or has had heart failure, how, when, and how much hormone to prescribe in those cases, and what are some absolute indications. But often it does come down to a shared decision making with the patient, and in terms of discussing with them what their level of congruence is, like and how much hormone are they willing to take or to cut down on in order to keep them, in order to reduce the risk of another heart attack or aggravating their heart failure. So I think these are all difficult questions that we sometimes see. So no good answers.
Mm-hmm. Yeah, I think on a whole, when it comes to hormone replacement therapy, it's advised not to potentially use in patients with prior stroke, prior heart attack, clotting disorders, prior breast cancer. Again, even in the menopausal world, we deal with some patients having such profound symptomatology. They're like, I cannot live this way. I'm having such terrible, lack of concentration, horrible hot flashes, things like that. So you always do need to weigh plus and minus. I think you're right, for each of these cases. But exactly as Minghao said, in a lot of them, you can mitigate like that in-between risk. Okay, you've got some risk factors that are uncontrolled, but if we control them, we'll feel pretty good about allowing you to do this. So it really, really definitely is an individualized thing. Absolutely. I agree. So if you guys had to develop an optimal, ideal sort of program, I don't know, I think, what are the key components that you think are most important for such a program for optimal LGBTQ health? I'm giving you millions of dollars today to design it.
Well, that is a lot of dollars, and in this utopia, I think starting at the initial level, the most basic unit of medical education is important. We always have to take it back to where physicians and nurses and other healthcare providers are learning about their patients. And I think it's important to incorporate LGBTQ education and LGBTQ care broadly and systematically into medical education. It shouldn't be 1 or 2 hours in your final year of medical school as like an elective. This is something that should be talked about at all stages, through all organ systems and through the longitudinal clinical care. So I think, if a significant portion of that millions of dollars would go towards medical education, and then also then, into residency training and fellowship training as well for cardiologists to be able to learn and familiarize themselves with both the risk and also how to manage some of them. And, we have been focused a lot today on, and rightly so, on the effects of hormone therapy and gender affirming care on cardiac health, but there are other aspects of LGBTQ cardiovascular care that we didn't get a chance so much to talk about, aside from just managing the social determinants of health that are more that are riskier in patients who are queer. There are also challenges around interactions between antiretrovirals for HIV, for example, and statins, and prep and how to manage that in terms of the interactions of some of the other drugs that we prescribe, both in medicine and in cardiology. So I think that, these are and how to manage HIV as an ongoing risk to your cardiovascular health, your coronary health, and with its elevated chronic inflammatory milieu that it poses on your body. So these are some things that we need to make sure medical students, residents, and fellows take away at the end of their training, so that they feel comfortable treating and helping patients who are queer. That's
That's such a great point, Caroline. I remember in medical school, we did not have a single talk on transgender health or how to treat transgender people. And we had maybe one talk on LGBTQ health. So, I mean, we had enough money for like standardized patients to come every 2 weeks. We should have, they should put some more money into training. That's absolutely right. And, from my point of view, what I'm thinking of in terms of innovations is that, these fancy, if you have a good insurance if you're an executive, right, you're invited for a executive checkup where they do everything in terms of lipids, weight, body composition, right? So why shouldn't our patients have the same treatment? Studies have shown that when you have coaching that occurs frequently, or check-ins that occur frequently, like every 2 weeks or so, then people are more likely to lose weight. But even for people who are not overweight, so an individualized, profile and coaching, I think would be very helpful for people. And also the opportunity for support groups and group exercise classes for our patients, I think would be very helpful. And so the individualized care, whether it comes in the form of an app, or an actual person to check in on the patient every couple of weeks, if money was no object, I think that would make a huge difference.
That's great. I think it's so important that you brought up all the things that we just have to be aware are a little bit more prevalent in this particular population, as you said. So HIV happens to be more prevalent. And yes, the good thing is that people are really living long with HIV. They're just experiencing, like the rest of the world, cardiovascular disease, in the long term that we're needing to prevent and manage. So absolutely being aware of that and, taking care of that. Cardiometabolic disease is sort of a term that has to do with a mix of different things that I think, especially in the transgender population that Minghao is describing, is sort of like sometimes your HDL is a little bit low, your triglycerides are a bit high, tend to have a little more weight around your belly, higher blood pressure, higher blood sugar, and those things are very common. So sort of being aware that this is something that we need to target. And I agree. I think, the reality is that, what makes some place a center of excellence really is, having the experts that are trained, pristinely to really take care of a certain population. And then what kind of programs do you really offer, as Minghao is describing? Like, you need the support groups, you need the education, the resources that will actually help people change their behavior and improve their risk. So great answer. I'm going to be delivering the money sometime tomorrow and you can get started.
Unmarked bills.
Yes, exactly.
We'll spend
it. Sorry, what's that?
We'll spend it well.
We'll spend it very, very well. Exactly. And I think for the last question, I'll just ask each of you, I guess since you have a sort of voice to this population, let's say, what kind of advice do you want to leave them with in terms of their health and what you want them to know?
I and all of us are fortunate to work in a city like New York, where, in comparison to some of the patients and other even doctors that I've met in other parts of the country, are subject to a lot more harsher laws, as well as harsher social stigmatization. So I think that it is easier for us to be able to care for these patients here. But I think that in what I would, and I know, and so what I want to say is that I recognize that it is hard to self-disclose your identity, regardless of whether you are bisexual or transgender or non-binary or just a gay man or a gay woman living in New York City. Even in a city like this, I think it can be hard to talk to your doctor about this. So I would encourage you to find your courage to discuss your gender identity, your pronouns, as well as your health habits, whether they are, taking your dog out for a walk 30 minutes a day, which would be great for your cardiovascular health, to, maybe on the weekends, I will partake in some cocaine. Those are things that are difficult to explain and discuss, but they're important for your doctors to know. So I think that, to be as honest as you can and to live that and as honestly as you can is important, both in life and in your medical care. The cocaine reference is mostly as an example of some of the substance use that certain populations and your community do experience. So
and it is known that it is more prevalent, unfortunately, in this community. And when I ask that question, honestly, even as a clinician, I ask in the most, unbiased way, because I want to know, I can't help you unless we really talk openly about whatever it is. So yes, definitely, it's important. I'm glad you point that out.
Yeah. So I think just along those lines, as a patient, don't be afraid to speak up for yourself. So be open, ask the questions that you need to ask to get the care that you need. And, if the first doctor that you come across or doctor's office does not mesh with you in terms of, treatment outlook, if they are not gender affirming, if you're a transgender person, then please, don't give up on us, go somewhere else. I promise you that clinics that are gender affirming do exist. So the city has resources. It actually publishes a PDF every year. And part of those resources include gender affirming care and LGBT friendly care. So when you search for doctors on like ZocDoc or other websites, you can actually filter to find doctors who are LGBT friendly. So utilize those resources. And something else that I would say specific to the transgender population is that, don't believe everything you read on Reddit and Instagram and Facebook. So there is propagation of some myths when it comes to treatment. So do discuss your concerns with your doctors. There's not a ton of research in this field, and we definitely need to do more research. But there's also some myths that we know not to be true. So be open with your doctors, with your healthcare providers, and then be bold when it comes to asking questions and advocating for yourself.
Really great advice. And we are, like I said, doing research. So I want to say thank you to the people who are actually enrolled, and there are registries, for patients for us to learn more. And, really kudos to the people who are already in those registries and helping us to understand more, and the research trials that are out there. And advocating, like you said, this happens to patients in general. They really need to. It's a tough medical world. You won't always get the care that you deserve. So you really need to keep, as you said, keep looking and find the right care team for you. Great. Thank you both for joining us today. This, I know, is a very open discussion about a really key topic. I hope that it raised awareness for everyone out there about how important this care is and how we need care teams to really do the best that we can for the LGBTQ community. So thank you everyone for joining us, and have a great night.
Thanks for having us. Take care. Bye-bye.
Bye-bye.